Hi, Dr. Garima here again, and today we'll be recording another session of scenario-based question for ADC Part 1. If you're appearing for the September 2024 exam, high time you start preparing, don't waste a single day. All the candidates who are preparing by themselves do solve the past papers. They are very, very important. And if you're already having a mentor and still watching this video, I hope your preparation is going on track. Share your experience of how it feels like preparing for ADC if you're a first timer or second or third timer. Leave it in the comments. It helps others to be motivated or they also feel like normal being in the same journey. So, anyways, let's start. 50 this today's session is based on dental implants. We'll discuss a bit of theory also about it. A 50-year-old gentleman requested an implant to replace tooth 1-4. 1-4 is basically the first premolar on the right side, which was extracted few months ago. So 50-year-old, so quite good age basically. He gives a history of profuse bleeding during his surgical extraction. Okay, so there is history of profuse bleeding, and it was a surgical extraction. He was a diabetic on anticoagulant and calcium channel blocker for hypertension and consumes alcohol on weekends. All right, quite a bit of medical history. So, whenever you get such a patient in your own clinic, anticoagulant, calcium channel blocker for hypertension, alcohol on weekends is okay. Good to know this history, but not so much important at the moment. The keyword here is diabetes, profuse bleeding, the history of profuse bleeding while surgical extraction, and patient being on anticoagulant. Now, whenever any patient mentions that they had a history of profuse bleeding, you have to get the INR checked before you perform any sort of surgical procedure that involves bleeding. Because if it's more, then you're not alarmed during extraction because you have the measures ready. Take a pen and paper, write down the local hemostatic agents that are used after extraction or during any surgical procedure. The INR, that is internationalized normalized ratio, is 1 usually, but patients who are on anticoagulant therapy between 1.5 to 2.5 is accepted. Hypertension does not specifically cause a problem in any dental procedure. It's just you have to be ready for any extra bleeding that might occur because such patients are usually on blood thinners, anticoagulant as mentioned. I'm talking in general. So read more about hypertension, but hypertension per se will never be a problem in any dental procedure, be it implants, be it root canals, be it extraction, if you are controlling the factors related to hypertension. So, whenever the history of hypertension is mentioned, just be careful what kind of local anesthesia you're giving and if the INR is fine or not. And you have local hemostatic agents ready with you. Okay. So, in the priority list of any surgical procedure that I have to perform, if I'm having diabetes and hypertension, then I'll give hypertension as the second priority. The first priority, which will always bug me, is the diabetes. Because diabetes is such a silent killer and it is such a complicated condition because of various reasons. And the first of them is if it's not properly controlled, then the healing gets delayed and there are higher chances of infection. Now, if the healing gets delayed and I'm doing an implant, then my osseointegration is not going to happen in a timely manner, which can lead to my implant failure. You understand that? So, diabetes has more of a weightage in how a dental procedure's outcome will come out compared to hypertension. Is that very clear? So, if a person is having a very controlled diabetes, healing still might be a little delayed, but chances of infection is less, means my chances of success of implant is more higher. But if it's an uncontrolled diabetes, then the chances of infection is higher, which means the chances of my implant failure is higher. So the major concern is diabetes. Always understand this. You want to read more about it, just Google like this effect of diabetes on dental implants. You see what all is mentioned here. Beyond infection risk, there is a chance of dental implant failure in some diabetics whose conditions are not properly controlled or monitored. In such cases, postoperative healing may be slow or poor, meaning that the implants don't fuse with the tissues in the mouth. This holds true for complicated extractions as well. If the patient is having very poorly controlled diabetes, the healing after extraction can be delayed, more of dry socket problems or more of infection problems. So you have to be very, very careful in treating diabetics, as periodontal disease are also very high in such patients. Compared to hypertension, hypertension or the blood pressure itself does not have any impact on dental implants or for any other dental procedure if you are taking care of the consequences that are caused because of the hypertension or hypertensive medications. Is this clear? Makes you feel more confident now. If two, three medical conditions are given, you have to see which will be the most, uh, uh, which is the condition that will affect your treatment to a greater extent, which medical condition you have to prioritize and give more weight to for monitoring. Now, having understood these concepts, let's go back to our own question. Now, during implant placement in the first upper premolar area, special consideration should be given to. Okay, so I have seen the medical condition, I've prepped up the patient, and I want to put an implant in the first premolar area. Now, as freshly passed out graduates, which most of you are, who have applied for PR in Australia or are already married off and living in Australia, have never practiced clinically, just passed out of the private college. Well, I understand you have not experimented with dental implants, or you have performed one, or you have seen the procedure being performed. So you will obviously lack a lot of knowledge of what considerations goes in placing dental implants for each tooth. So yes, you have to brush up on your theory a bit. You can open a PowerPoint presentation, read in general about implants in dentistry, and then you can be a little more specific and search which tooth implants has which all considerations to be given. Now, for the first premolar, it's an aesthetic zone. See, when I smile, you can if I have a wide smile, you can see my premolar. So it's like a corner of your smile. So the aesthetics is very important. So you have to take care that the implant that you're placing is little towards the buccal side because when the bone formation happens, the gum will form properly over it. The gum is always attached to the bone, not the implant. Understand that. So to have that aesthetic gum line, the bone has to form over the implant. So if you have placed the implant more towards the palatal side, then that much effect of the gum emergence of the crown when you're going to give it is not going to come as much as it will come if you're placing the implant on the buccal side of the bone. Also, the height of the bone in the premolar area is a little longer, so that actually works in the favor of the implantologist. But the width of the bone sometimes is less. So a lot of bone augmentation is usually done in the premolar area. So another thing that may affect the quality of the implant or the way you're going to put the implant is the root of the canine. Now canines have very long root. Everybody knows that. One of the longest tooth in the mouth, the maxillary canines. Now, when the root is straight, it's great. But sometimes the root is like and it's curving towards the distal side, which means it's coming in the way of the premolar. Now, the canine root is like this, but the premolar roots are like buccal and palatal. They are not mesial and distal like the molars. So the upper premolar roots are like buccal and palatal, but the canine root will curve in case it's curving in some instances towards the distal side. Now, when you're going to place the implant, you have to make sure that it's not hitting the canine bone, I mean, the canine root. So, that is one major consideration. Another thing is the mesial curvature of the second premolar root. Now, you're going to place the implant in the first premolar, and then there is a second premolar. Now, if one of its root, buccal or palatal, is curving mesially, again, it's going to hit on your implant, right? So, you'll have to make sure that the roots of the adjacent teeth are not coming in the space in which you're going to put the implant. So, when I read this question during implant placement in the upper first premolar area, special consideration should be given to curved apex of the adjacent canine, maxillary sinus, or the mesial curvature of the second premolar root? My answer is A and C. Maxillary sinus, I'm not so much bothered about because, like I mentioned, the height of the bone out in the first premolar area is quite nice. Yes, I would be bothered about the maxillary sinus if I was doing a molar implant, the maxillary molar implant, or the second premolar to certain extent. But for the first premolar, yes, it may happen that the maxillary sinus is dipping in that area, but that would be on my second priority list. My first priority list would be to see the roots. You understand? So hence my answer would be A and C. Though answer B is not wrong, but my weightage would be for A and C. Now, whenever you have such two answers correct, I have already mentioned in many of my previous videos that usually these questions go as unmarked questions. Like there are 40 unmarked questions. I'm repeating again. That means out of 280 questions, 40 are unmarked, which technically comes down to 10 questions every paper. You have four papers, which means that two answers are correct. And that question will not be scored. So don't sweat yourself out on such questions. If you feel any of these two are correct, just choose it. Because anyways, 10 questions out of 70 questions in each exam will not be accounted for. So you'll be marked only on the 60 questions. Yeah, that's how ADC exam is, but you will not know which questions are unmarked. For a better emergent profile of an implant placed in the upper premolar area, the implant should be placed. Now we discussed about this. Emergence profile is how the crown is emerging from the gum, and the gum is attached to the bone, the gingiva basically, and the bone has to form over the implant. So if I want a very natural aesthetic look, where I should be placing my implant under the central fossa, no, that is basically the extraction hole. No, I'm not going to place over that. And you cannot place an implant over that. You have to place it in the bone. You want osseointegration to happen. Under the buccal cusp, yeah, under the palatal cusp, then it would be too far away. Yes, you can give the crown resting on the palatal side, but on the buccal side, it would be just attached over the gum. It's not going to give a good profile. So on the buccal cusp is the right answer. Subcrestal 1 mm? No. Now, the initial radiograph of choice in dental implantology treatment is now very tricky question. Okay, it may seem very straightforward at first, and initially you'll be very tempted to choose CBCT, but no, that is not the right answer. What is the first key word here? The most important, the initial radiograph of choice. Again, whenever a question says the initial treatment of choice, the initial radiograph of choice, it means whatever options are given. 1 second, my son just woke up. Yes, my son woke up, so I just got him. So the initial radiograph, or whenever such words are used, it means all the options that would be given to you would be correct. You have to choose which is the first choice. Now imagine a new patient walks in your clinic and he says, I want an implant. Would you directly jump to CBCT? No, you'll take an OPG first to see the status of the side teeth, whether enough space is available mesiodistally, if one of the tooth is supra-erupted or the distal tooth is mesially tilted, or if any root piece is remaining in that area, what is the condition of the rest of the teeth in the mouth, what is the status of the tooth where the implant has to be done, is it near any nerve, any anatomical landmarks. So a first gross picture will always be an OPG. Only when you have decided to proceed with the implant, then you will take CBCT of that exact site. You understand? So don't jump on the specific radiograph just because it's given the option. Many people have made mistake over it, and then it becomes a really silly mistake because this kind of question would definitely be marked. And it's like you know the answer, but you didn't think it through. So the initial radiograph of choice in dental implantology treatment is always ortho pantomograph, that is OPG. Write it down, understand the concept and logic behind it. Imagine yourself as a clinician who's sitting and a new patient is coming. You will never jump to a CBCT, you'll always take an OPG. Understood? Now we come on to what is the most significant patient factor that can affect the long term success of an implant in this case? Again, what is the keyword here? Most significant patient factor. That means, again, all the options that would be given to you, all of them would be correct. Now you have to choose the most significant one. Anticoagulant treatment, high blood pressure, diabetes, and alcohol consumption. In the start of this video, we already discussed that when you have multiple medical conditions, you have to choose which one has the highest weightage and the most priority that you would be given to. Now, based on the theory that we have discussed, we can clearly choose diabetes without getting confused at all. Understood? If not, pause the video, go back to the starting explanation, see what I have mentioned, write it down again, and proceed. Very logical, scientific reasoning I have given. Now, you need to assess the quality and quantity of bone for implant placement. Which factor will determine your radiographic technique? Okay. Now, this is a very specific question. It's saying that I need to assess the quality and quantity of bone. Whenever you say quantity of bone, it means how much bone is available for you to place the implant. Now, if your implant is of, say, 7 millimeters or 8 millimeters or 5 millimeters, you need to make sure that you have enough bone for that kind of length. Now, whenever the question is asking the quantity of bone, you have to choose a radiographic technique which will give you the linear measurements. Basically, now this I think you be a graduate or not or a freshly passed out person. You know that there are softwares on the radiograph where you can measure the linear measurements, like you move your cursor and it marks how much length is available. That is called as linear measurement. Image resolution, breadth of coverage, visibility of important anatomical structures is not going to give you the quantity of bone available. Only the linear measurement is going to give you that. So that is the answer. I hope things are clear and you're more well equipped with the knowledge of dental implants. Many questions would be asked on dental implants for that matter. And one of the questions that can be asked is to calculate how much distance is required between two teeth when you're going to place an implant. That is another question of which explanation I've already given in one of the videos. If I'm going to come across the same question in any other of the mocks, I will repeat it again. But go through that. So these two questions on dental implants will always be asked. Again, one more question that can be asked is periimplantitis, like how much bone loss would make you classify it as peri-implant mucositis or peri-implantitis. So these three questions expect in the exam because ADC expects you to know this as a general dentist. Somehow they feel you should know about dental implants, though it comes under the specialty coverage area. But somehow they expect you to know that, hence you have to know that. Uh, yeah, my son is having fever again since today morning. Since last Friday, it's been on and off. Last 2 days, at least he didn't have fever, but then he developed cough. Today morning, he again ended up with fever, so then he just wants to sleep like this. My back's broken. But yeah, these are the motherhood things that every mother has to go through. And I actually, when I went to Mumbai this last week, I actually told my mom, Mama, I'm sorry for what all I have put through you when I was a child. And she started laughing. But yeah, I had to say that because, yeah, it's not verbalized, it's never appreciated by the male members of the family. They are doing the outside work to earn and support the family. Raising a child is not easy, especially when you're working, and even if when you're not working, it still takes a lot of toll. Like you barely get time for yourself, for your sanity. And of course, you start worrying when the child will get better, because you cannot see your children just being so inactive because they're down with fever and viral infections, etc. You want your son or daughter to play happily and do the regular stuff. So, yeah, it does take a toll. But yeah, that's it. So, I'm going through this phase. Hope he gets better soon. So, leave your comments on what else you want me to take the video about, and how you liked this one. And I hope your concepts are more clear. Bye bye.